Okay. So good evening everyone, and today my topic is Aorto Iliac aneurysms evaluation, decision making and medical management. And as per definition, a true arterial aneurysm is defined as increase to 1.5 times the normal arterial diameter with involvement of all the three anatomic layers. And in the infrarenal abdominal aorta, an aneurysm is traditionally defined as diameter greater than 3 centimeters are more than 50% larger than the proximal arterial segment, measured in either AP or a transverse dimension in a plane perpendicular to longitudinal axis of the aorta. Now, as for epidemiology and risk factors concerned, age is the most significant risk factor for the development of abdominal aortic aneurysm. And as the age increases, there is the increased risk of developing abdominal aortic aneurysm. In the age group of 65 to 69, the odds ratio is 5.4, and in the age group of 75 to 79, the ratio increases up to 14.5. And second risk factor is smoking. Smoking is the only modifiable risk factor associated with the abdominal aortic aneurysm, and more than 90% of the patients with abdominal aortic aneurysm have smoked cigarette at some point in their lifetime. And abdominal aortic aneurysm is the second only to lung cancer in epidemiological association to cigarette smoking. And current smokers have more than 7 times more likely to have an aneurysm than non-smokers. And each year of smoking relatively increases for the development of aneurysm by 4%. And atherosclerotic disease, hypertension, male gender, hypercholesterolemia, and family history. Family history, first degree relative of a abdominal aortic aneurysm patient have a 20% chance of getting a abdominal aortic aneurysm. And the negative risk factors include female sex, African American race, and diabetes. And this is the slide taken from the SVS guideline showing the with the increase in age, how much increase in the risk of the developing aneurysm. And the age group of 55 to 59, it is around 11, and in the 80 to 84, it is 35. And as compared to race, as I told earlier, Hispanic, African American, and Asian, there is negative predictive value. And high blood pressure, coronary artery disease, and family history, high cholesterol, diabetes, peripheral arterial disease, and they have higher chance of getting abdominal aortic aneurysm. And this is the smoking. As for smoking is concerned, number of pack years and the duration of smoking in less than 10 years, less than 0.5 pack years, it is showing less risk. And with the increased smoking for 11 to 20 years and more than 35 years, there is a significant increase in development of abdominal aortic aneurysm. And those who quit smoking less than 5 years ago, the risk is -1, and 5 to 10 years ago, that is -4, and more than 10 years ago, it is -9. And with who eats fresh fruits and vegetables more than 3 times a week, it is a negative, it's a good factor. And who exercise regularly more than 1 time a week, it is negative. Come to rupture risk. Risk of rupture mostly occur in patients with abdominal aortic aneurysm of diameter 5 to 5.5 centimeters. The risk of rupture was independently associated with more in female sex, larger initial diameter, those who are smokers, and low forced expiratory volume at 1 second, and higher mean blood pressure. And the sacral aneurysm has more chance of rupture than the fusiform aneurysm. And there are certain indicators in CT angio we can find out, like presence of a dissection or mural thrombus or a dissection of the peripheral calcification of the aneurysm sac. There is increased chance of rupture. This is a diameter in centimeters with the risk of rupture, and 3 to 3.9, there is a 0.3% percentage of risk of rupture, and when it is more than 7, it is more than 30% of risk of rupture is there. And associated aneurysms, the involvement of adjacent arterial segment is not uncommon, it is common, most common in juxtarenal or suprarenal and in iliac artery. In iliac artery, it is most common involved segment is common iliac artery, it is up to 70%. This is angiographically detected lesions. When they are doing angio, they found that associated lesions along with abdominal aortic aneurysm. We can see suprarenal extension is seen in 6.7% of the patients, and in renal stenosis or occlusion is seen in 18% of the patients. In accessory or multiple renal arteries is 13.5% of the patient, and iliofemoropopleteal aneurysms in 34.7%. There is significant risk of getting iliofemoropopleteal aneurysms along with abdominal aortic aneurysm. And when compared to pathophysiology, there is the embryological process appears give rise to a region of heterogeneity in different parts of the aorta, with smooth muscle cells of the thoracic aorta derived from neural crest cells, and smooth muscle cells of the abdominal aorta is derived from the mesodermal cells. This heterogeneity gives clearly variation and in relation to cytokine susceptibility and secretion, leading to the formation of aneurysm. This heterogeneity is also reflected in tissue characteristics of aortic media. In thoracic aorta, the media contains 55 to 60 lamellar units, whereas in abdominal aorta, it is around 28 to 32 lamellar units, which makes more abdominal aorta more prone for aneurysm development. And biomechanical stress of the aortic bifurcation also leads to increased risk of getting abdominal aortic aneurysm. In the pathogenesis, there are four mechanisms mainly related to AAA formation, that is proteolytic degradation of aortic wall connective tissue and inflammation and immune response, and biomechanical wall stress and molecular genetics. This is the slide showing what is the mechanism actually happening. This is the first we can see intraluminal thrombus, which is itself is a laminated layer. In the intraluminal thrombus, there is RBC hemoagglutination occur, which releases pro-oxidant hemoglobin, and the leukocytes releases proteases like elastase, matrix metalloproteinases 8 and 9, and polymorpho releases these MMPs 8 and 9, elastase and plasminogen, which leads to MMP activation, which are basically proteases which cause the lysis of these elastin and collagen in the media, which causes smooth muscle cell apoptosis, and the extracellular matrix digestion leads to fragmented elastin and collagen. And in the adventitia, main thing happening is angiogenesis, and with the collagen accumulation leads to neoangiogenesis. The in the intima, the main in the media, major thing happening is wall thinning and medial loss of smooth muscle cells, leading to elastic degradation and adventitial inflammation due to the presence of intraluminal thrombus. And the changes in the adventitia are inflammation, leading to form of extensive periaortic adventitial infiltration of leukocytes and macrophages and mast cells, leading to neoangiogenesis. Along with the continuous remodeling, there is formation of abdominal aortic aneurysm. Comes to diagnosis, history, patients with AAA are typically asymptomatic. Some patients present with non-specific lower back pain or abdominal pain, and sometimes they have pulsations on their abdomen. They say pulsatile abdominal mass. In physical examination, we should also, and whenever we are examining a patient of a AAA, we must look for the other associated aneurysms like iliac aneurysms and femoropopleteal aneurysms. This is a slide. This is a slide from SVS guidelines showing the physical examination recommendation. In patients with the suspected or known abdominal aortic aneurysm, they are recommended that always look for a femoral and popliteal aneurysm. Coming to assessment of the medical comorbidities, in patients with active cardiac conditions like unstable angina, decompensated heart failure, severe valvular disease, and significant arrhythmias, they always suggest a cardiac consultation along with a 12-lead ECG and 2D echo and non-invasive stress testing before planning for any open procedure or endovascular procedure. In assessment of when coming to the patient is already underwent coronary stenting and an antiplatelet medicine, then we should stop those medicine 10 days prior to for an open procedure, and to prevent the benefits, get the benefits of preoperative bleeding and stunt thrombus should be discussed with the patient. And we should continue the beta blocker if he is already taking, and don't start the beta blocker therapy in the immediate perioperative period. and to prevent the perioperative stroke. And in patients with pulmonary diseases like COPD, it should be mandatory to get an room air ABG and pulmonary function test. And to stopping of the smoking is at least 2 weeks before aneurysm is the recommendation. And they should administer pulmonary bronchodilators for at least 2 weeks before aneurysm repair in patients with history of COPD or abnormal results of pulmonary function tests. In patients of renal patients, it is a pre and post op hydration is mandatory thing. We should give 1 ml per kg per hour hydration before the procedure. And if he is on taking metformin, we should stop at least 48 hours before before the planned procedure, as there is chance of lactic acidosis, which is fatal to the patient. And they recommend perioperative transfusion of red blood cells if the hemoglobin is less than 7, and if the platelet count is less than 1.5 lakh, we should assess hematological consultation to rule out any other hematological pathology. And, coming to aneurysm imaging, the imaging is by ultrasound, CT, and MRI. Ultrasound is mainly a modality for screening the patient, and to confirm and to plan for the procedure, we need a coronary computed CT angiography, which provides excellent details about anatomy and uh, health of anatomic information and defects in the vessel calcification, thrombus, and concurrent arterial occlusive disease also. It also permits 3D reconstruction, which is very valuable in planning for the EVAR procedure or whatever the procedure you are planning. And the drawbacks associated with the CT angiography include exposure to radiation and contrast media, which is a risk in kidney patients. And when compared to MRI, only drawback with the MRI is it cannot provide the details about the calcification of the aortic wall. And MRI utilizes gadolinium, which is associated with nephrogenic systemic fibrosis in patients with low GFR. And these are the guidelines for the SVS, and they recommend ultrasound when feasible as the preferred imaging modality for screening and surveillance, and CT from outer wall to outer wall measurement, CT for the procedure, and one-time ultrasound screening for men with or women over 65 to 75 years of age with history of tobacco usage, and the ultrasound screening in first degree relatives of patient present with an AAA, and the screening should be performed in first degree relatives who are between 65 and 75 years of age, or in those healthy individuals who are more than 75 years. They suggest one ultrasound screening for in men or women older than 75 years with the history of tobacco usage, in otherwise good health who have not been previously received ultrasound examination. The initial ultrasound screening identified an aortic diameter of more than 2 centimeter, less than 3. They suggest a rescreening after 10 years. And if it is between 3 to 3.9 at interval of every 3 years, if it is between 4 to 4.9 centimeters at interval of 12 months, and if it is between 5 to 5.4, imaging at 6 months interval. And if there is any symptoms like recent onset back pain or presence of any pulsatile epigastric mass, they require an immediate CT scan to evaluate. And when to treat, the decision to treat is to diagnose the aortic aneurysm, they should refer to a vascular surgeon at the time of diagnosis. And we recommend repair for the patients who present with A and likely to be attributed to the aneurysm. And we recommend elective repair for the patient at low or acceptable surgical risk with a fusiform aneurysm that is greater or equal to 5.5 centimeters. They suggest elective repair in case of saccular aneurysm, and they suggest repair in women with a diameter of 5 to 5.4 in maximum diameter. In patients with a small aneurysm like 4 to 5.4 centimeters who require chemotherapy, radiation therapy, or solid organ transplantation, they suggest a shared decision making along with the involved groups before suggesting a treatment option. And the medical management, they recommend smoking cessation to reduce the risk of abdominal growth aneurysm and rupture. And they suggest not administering statins, doxycycline, roxithromycin, or ACE inhibitors or angiotensin receptor blockers. for the sole purpose of reducing the risk of abdominal expansion and rupture. Even in animal studies, they show significant reduction in the size, but in human studies, they didn't show any benefit with these medicines like doxycycline or administering statins or angiotensin receptor blockers. And they didn't they didn't suggest any beta blocker therapy for the sole purpose of reducing the risk of abdominal expansion and rupture. And these are the indications for intervention. In general, the size criteria for elective repair is 5.5 centimeters per man and 5 centimeters per woman, are a 12-month growth rate of equal or greater than 1 centimeter in both the sexes. Both UK small aneurysm trial and Adam trial documented that the surveillance of the aneurysms between 4 and 5.5 centimeters is safe with the compliant patients. Additional indications for elective or early intervention include saccular aneurysms, dissection of the thrombus, and fracture of the saccular calcification. This is the slide showing the diameter with the risk of rupture for untreated aneurysms within 5 years. 5 to 5.9 centimeters, there is 25% risk of rupture, and 6 to 7 centimeters, there is 35% risk of rupture, and the more than 7 centimeters, it is more than 75%. And the aneurysm diameter reaches 5 centimeters, the risk of rupture is generally considered to be higher than the operative risk. Timing for intervention, they recommend immediate repair for patients who present with a ruptured aneurysm, and they should repair symptomatic aneurysms to be delayed to optimize coexisting medical conditions, and the patient be monitored in the intensive care unit setting with blood products available. And this is a slide showing when to intervene. If the aneurysm is ruptured, then patient amenable for repair, then endovascular repair or open repair. If it is not ruptured, then we will assess for the rupture risk. If it is low, then medical management. If it is high, then we will look for life expectancy. If life expectancy is low, then go for medical management. The life expectancy is as high, then we will assess the operative risk. If the operative risk is low, then repair by either open or endovascular method. If the operative risk is high, good endovascular anatomy, go for endovascular repair. Sir, Kapish sir.
Yeah, Surendra.